Good afternoon. Thank you, Team RML, for inviting me as a member of faculty of your prestigious APPEC and postgraduate series. It's a very pertinent topic which has been kept in the afternoon session, electrolytes and electrolyte imbalances. For the residents, it's a very relevant and pertinent topic. They will be facing it not only in their theory, OSCE, and the practical exam, but also in their day-to-day practice, especially in the emergency surgeries, ICUs. So let me introduce the first speaker. We have Dr. Michelle Gulnabani, who's an assistant professor from UCMS, whose area of interest is difficult airway, obstetric anesthesia, trauma. Dr. Michelle, she'll be speaking on sodium, potassium. Over to Dr. Gulnabani.
A very good day to all present. I'll be discussing about sodium-potassium disorders and their management. I'm Dr. Michelle Gulnabani, Assistant Professor Anesthesia at UCMS Delhi. So let's see what are osmolarity and osmolality, because sodium disorders are very much linked with water homeostasis, and their classification and diagnosis is based largely upon the extracellular fluid volume status. So osmolarity is the osmotic activity per volume of solution, which includes the solutes plus water, and is expressed in milliosmoles per liter. However, osmolality is the osmotic activity per volume of water, and is expressed in milliosmoles per kg of water. The normal plasma osmolality ranges from 280 to 290 milliosmoles per kg, and it is calculated using the plasma sodium, glucose, and BUN by this formula. So let's see the relationship between the osmotic activity and the movement of water between the fluid compartments. Suppose there are two fluid compartments separated by a semi-permeable membrane. The solutes normally balance themselves across both the compartments. However, if the extracellular fluid volume is hypertonic and relative to the intracellular fluid, the water will move from the hypotonic to the hypertonic compartment, and the reverse will happen if the ECF is hypotonic. So what is effective plasma osmolality? If you remove the urea component from the derivation of this plasma osmolality, you get the effective plasma osmolality. So we see the difference between the effective and the normal plasma osmolality is approximately only 5 milliosmoles per kg of water. The sodium concentration in the ECF is the principal determinant of the distribution of total body water in the intracellular and extracellular fluid compartments. So sodium is an important function because of its major cation in the ECF. It helps to maintain the osmotic pressure. It helps in initiation of the action potential, maintains the normal neuromuscular membrane function, and its daily requirement ranges from 5 to 15 gram. The normal sodium levels are 135 to 145 milliequivalents per liter. So what is hyponatremia? It is a sodium levels of less than 135 milliequivalents per liter, occurring in about 40 to 50% of the ICU patients, especially the neurosurgery ones, and 22% of the hospitalized patients. So variations in the total body water are the ones which subdivide the hyponatremia into the three types based on the volume status, into hypovolumic, euvolumic, and hypervolumic hyponatremia. So as we see, let's see in all the three types. In hypovolumic hyponatremia, the total body water is less, and the total body sodium is also greater in extent, being less as compared to the water. So we experience hyponatremia when we check the levels. How we can differentiate these two is basis of urine spot sodium. If it is more than 20, we think of renal causes, diuretic excess, and mineralocorticoid deficiency. If the urine spot sodium is less than 20, we think of extra-renal causes like vomiting, diarrhea, third space loss, burns, etc. Now let's come to euvolumic hyponatremia, in which the total body water is increased, but the total body sodium is neither increased nor decreased. But however, we get a hyponatremia on evaluation. And in that, you have urine spot sodium of more than 20. The most important cause for this is SIADH. Besides that, glucocorticoid deficiency and hypothyroidism are the other causes of euvolumic hyponatremia. And third is the hypervolumic, in which the total body water is increased also, and the total body sodium is also increased. However, the total body water is more increased as compared to the sodium. This is further divided on the basis of urine spot sodium. Having more than 20, it means a renal cause like acute or chronic renal failure. And if the urine sodium is less than 20, we think of volume overload states like cirrhosis and cardiac failure. So a word about pseudo-hyponatremia. As the name suggests, it's basically a hyponatremia which is detected during the normal analysis. Causes could be hyperlipidemia or hyperproteinemia because these reduce the absolute water content for a given volume of plasma. The sodium levels per unit plasma are reduced, and thus the analyzer measuring the sodium concentration per unit volume of the plasma will show hyponatremia. This can be clearly found out if you use iron-specific electrodes. And the serum osmolality measurements are not affected by pseudo-hyponatremia. Signs and symptoms can range from anorexia, nausea, lethargy, apathy, muscle cramps, and the symptoms from abnormal sensorium, agitation, disorientation, to coma and death. So acute hyponatremia is when it develops within 48 hours of prior plasma sodium levels being normal, and chronic usually persists and develops slowly for more than 48 hours. Let's see this diagrammatic representation of how the brain adapts to this hyponatremia. So immediate effect of a hypotonic state is water gain and low osmolality. And when there is chronically or slow adaptation, there will be the loss of sodium, potassium, and chloride. And these organic osmolytes will be slowly lost from the cells to maintain their intracellular volume. If you do an improper correction by rapidly correcting the hyponatremia, which is chronically there, these organic osmolytes, which are being lost when the hyponatremia is given, there will be rapid loss of water from the cells, resulting in cell shrinkage and osmotic demyelination. However, if proper therapy is given over a controlled way and slow rate, then these organic osmolytes, which were being lost when the patient was hyponatremic, tend to be retained by the cell again. So the major complication of central pontine myelinosis or osmotic demyelination syndrome, which is because of cell shrinkage, will be avoided to a large extent. And then you will get your normal brain with normal osmolality. Common causes of acute hyponatremia would be post-operative premenopausal women, infusion of hypotonic irrigating fluids, glycine irrigation, TURP surgeries and uterine surgeries, polydipsia, and exercise-induced. So these are the four situations which we can have: a normal patient, of course, with normal osmolality and serum analyzer showing it normal. Then the various types of which are important is the hyperglycemia. Now in hyperglycemia or IV mannitol, we see that the serum osmolality is high and the serum sodium measured by the autoanalyzer will also be low and iron-specific electrodes will be low. However, in pseudo-hyponatremia, you'll have a normal osmolality and the iron-specific electrodes will show a normal sodium values. However, the serum sodium by an autoanalyzer will be low. So it's a falsely low indicator. That's why the name pseudo-hyponatremia. So diagnosis is based on careful assessment of the volume status, measurement of plasma osmolality, urine electrolytes, and urine osmolality. The gold standard for the diagnosis of hypovolemic hyponatremia is that the plasma sodium will correct after hydration with normal saline because the cause is hypovolemia. So the clinical context often helps us to come to the diagnosis of the etiology. And the two most common causes of hypovolemic hyponatremia are diuretic use and cerebral salt wasting syndrome. And CSS, or this syndrome, is seen in neurosurgical patients post-infections, tumors, or procedures. So a word about SIADH. It's the most common cause of euvolemic hyponatremia and due to non-physiological release of AVP from the posterior pituitary or an ectopic source. So high levels of ADH are secreted intermittently at an abnormally low threshold or continuously despite low osmolality. So nausea and pain are potent stimulation for ADH and are common cause of SIADH in the post-operative hospitalized patients. So there's a list of drugs, which is anticonvulsants, antineoplastic drugs, immunosuppressive agents, and other causes which result in SIADH. And the important ones for us are the post-operative causes like nausea, pain, stress, and of course the CNS lesions are there like tumors, CVA, etc. Malignancies are there which cause an ectopic SIADH. And the lab values which are of importance to diagnose SADH are the first three. It is euvolumic hyponatremia. There's a decrease in the plasma osmolality. However, the urine osmolality is increased, more than 100 milliosmoles per kg, and the urine spot sodium is more than 40 milliequivalents per liter. So, how do we manage hyponatremia? The three goals. Firstly, you'd see the presence or the severity of symptoms, and that will guide the urgency for the treatment. Secondly, with chronic hyponatremia, we have to be and think of the risk of ODS if the plasma sodium is corrected at the rate more than 8 to 10 millimole in 24 hours. Thirdly, the response to treatment is unpredictable. Hence, treatment with a regulated and frequent monitoring of the plasma serum sodium concentration is important. In asymptomatic patients, the plasma sodium should be raised by no more than 0.5 to 1 millimole per liter per hour and less than 10 to 12 millimole per liter over the first 24 hours. Acute symptomatic hyponatremia, when it is less than 110 to 115 millimole per liter, presents with altered mental status, seizures, coma, and requires a more rapid correction. So in that case, the serum sodium levels can be increased by 4 to 6 milliequivalents per liter in the first 1 to 2 hours. However, the final plasma sodium concentration should not increase by 120 milliequivalents per liter. Supportive therapy is required in acute symptomatic hyponatremia, and intravenous loop diuretics have no role in the treatment of acute pulmonary edema. AVP antagonists have also not been approved in the management of acute hyponatremia. So the rate of the infusion of this hypertonic saline has been explained by this formula. Suppose there is a 60 kg woman with a sodium of 120. The deficit would be 0.5 into 6, which is the total body water, multiplied by 130, which we assume is relatively the normal concentration, minus 120, which is her sodium levels, and that will be equal to a deficit of 300 milliequivalents. So if you use 3% hypertonic saline and you keep the rate of correction as 0.5 millimole per liter per hour, the rate of infusion comes out to be 29 ml per hour according to this formula. For chronic hyponatremia, the plasma sodium should not rise faster than 0.5 milliequivalent per liter per hour and less than 18 milliequivalent per liter in the first 48 hours. Rapid correction can lead to ODS, which is characterized by dysarthria, quadriparesis, and loss of consciousness. Chronic hyponatremia poses a greater risk for this complication than acute hyponatremia. So let's talk about hypervolemic hyponatremia, which is primarily due to CHF, and it will improve after correcting the underlying cause. So ACE inhibitor therapy has a role in that. Another measure which will help in the diagnosis and the treatment would be a urine to plasma electrolyte ratio, which gives a quick indicator for electrolyte-free water excretion. So with a ratio of more than 1, urine sodium plus potassium divided by plasma sodium ratio, water should be restricted to less than 500 ml per day. If the ratio is 1, then between 500 to 700 ml per day. And with those with a ratio of more than 1, it should be less than 1 liter per day. So patients with SIADH respond to a combined treatment of oral furosemide and oral salt tablets. Other treatment modalities in SIADH which have been used is demiclocycline. Monitoring of the renal function is important because it is nephrotoxic. Vasopressin antagonists, this is convaptan and tolvaptan, can be used as alternatives to fluid restriction in patients with euvolumic or hypervolemic hyponatremia, except in renal failure. Convaptans are given intravenously. The dose is 20 milligram followed by a continuous infusion of 40 milligram per day for 96 hours. And tolvaptan is the other alternative. And hypervolemic hyponatremia patients can also benefit if they are asymptomatic with fluid restriction and furosemide diuresis. So what is the importance of this hyponatremia to the anesthetist? We classify them into 3 states: mild, moderate, and severe. The values ranging from 130, 120 to less than 120. And it may present preoperatively as an existing disorder or as a consequence of perioperative events. Even mild preoperative hyponatremia is associated with increased 30-day mortality, major cardiac events, wound infection, and pneumonia. So search and optimization of the underlying disease is of importance. And in the anesthetic considerations, also we see that plasma concentration of less than 130, around 130, are generally safe for patients undergoing GA. Lower concentrations than this can result in intraoperatively decrease in MAC, and postoperatively you can experience agitation, confusion, and somnolence. And there are various surgeries like TURPs in which there is significant absorption of water from the irrigating fluids, and this can result in water intoxication and hyponatremia. These hypovolumic hyponatremia patients are more sensitive to the vasodilating and the negative inotropic effects of volatile anesthetic agents. And intraoperatively, if you have to supplement hypertonic saline, it should be done via an infusion pump. Invasive hemodynamic monitoring can be attempted for patients with hypervolumic hyponatremia to assess their fluid status as well as to take a good assessment of their cardiac function. And these patients will also be particularly sensitive to the sympathetic blockade from regional techniques. In moderate to severe hyponatremia, non-urgent surgery should be postponed to allow gradual correction of the hyponatremia. The incidence of post-operative hyponatremia is 1 to 5% with children and premenopausal females, particularly at risk for neurological complications at values of 128 milliequivalents per liter. So 8% of the hyponatremic patients develop encephalopathy, of whom 52% may suffer permanent neurological damage. So prevention of post-operative hyponatremia should be the key goal of post-operative fluid therapy based on limiting the free water administration to pure maintenance requirements of 1 to 2 milliml per kg per hour. So then we'll see the key points would be the treatment will depend on the underlying correction and the situation. Lab assessment will include plasma osmolality, urine osmolality, and urine sodium. So a normal volume status in the presence of hyponatremia points towards SIADH. So what is hypernatremia? Now, when we come to hypernatremia, we see that the serum sodium levels are more than 145. It's has a less common occurrence than hyponatremia, but a high mortality ranging from 40 to 50%. And majority of the cases are due to loss of water. However, there also may be cases because of primary sodium gain or water deficit. Commonly seen in debilitated patients in the ICU, post-operatively in infants, commonly due to diarrhea, old patients. Etiology ranges from impaired thirst to salt diuresis, like osmotic diuresis in DKA patients, excessive water loss. Renal causes could be diabetes insipidus or drug-induced because of loop diuretics. Extra-renal causes will be insensible water losses, GIT losses. And then, of course, you have the primary sodium gain because of soda bicarbonate administration or excessive administration of sodium chloride itself. So the signs range from polyuria, polydipsia to irritability and lethargy. And the symptoms range from muscle twitching, hyperreflexia to focal generalized seizures. So in chronic hypernatremia, what happens? These patients are particularly prone to the development of cerebral edema and seizures if rapid correction is started. That is more than 0.10 millimole per day. So symptoms are profound when hypernatremia develops acutely, same like hyponatremia. And the mortality rates, however, range up to 75% have been described at serum sodium levels of 160 milliequivalents per liter. So in patients with persistent urine output of more than 100 ml per hour, hypertonic plasma, DI or diabetes insipidus should be considered. So which is further divided into two types, central and nephrogenic. In central, the osmolality of the urine ranges below 200 milliosmoles per liter, but nephrogenic, its osmolality is between 200 to 500. So central, the causes could be the traumatic brain surgery, meningitis to neoplasms, and it could also be an autosomal dominant inherited situation. So there's an absolute decreased release of ADH from the posterior pituitary. And nephrogenic, the cause is a defect in the end organ responsiveness to ADH. Again, it can be inherited or acquired, and sporadically in critically ill patients on amphotericin, dopamine, lithium, etc. And pregnant women in second or third trimester sometimes develop nephrogenic diabetes insipidus due to excessive elaboration of vasopressinase by the placenta. The defect is not as severe as central diabetes insipidus. So how we can differentiate between the two is the vasopressin test. So once you give vasopressin, central diabetes insipidus, the urine osmolality will increase by 50% almost immediately. However, nephrogenic, the urine osmolality remains unchanged after even giving AVP. So SIDH, diabetes insipidus, is a condition in which there is inappropriately dilute urine less than 300 milliosmoles per kg in combination with hypernatremia and high serum osmolality. So the diagnosis of DI, we need to daily measure the urine electrolytes and accurately record the urine volume, and estimation of the daily fluid intake is crucial for this diagnosis. Now the management, plasma sodium should be corrected by not more than 10 millimole per day, and it may take longer than 48 hours with patients with severe hypernatremia. So patients with central DI benefit from intravenous, intranasal or oral desmopressin. Nephrogenic diabetes insipidus due to lithium may reduce the polyuria and with amiloride. Thiazides and NSAIDs have also been used to reduce polyuria due to nephrogenic DI. So it's important to estimate the total water losses. We see the water deficit by the total body weight formula, ongoing water loss, and insensible losses. Once we calculate that, the total deficit, we have to replace it. Now the rate of replacement is the decrease in plasma sodium should not exceed more than 0.5 milliequivalents per liter per hour for free water replacement. About half the free water can be replaced in the first 12 to 24 hours of replacement. The importance to the anesthetist for hypernatremia, the surgery should be delayed until hypernatremia has been corrected and its associated symptoms. Frequent sodium measurements and urine output monitoring will be required, and invasive hemodynamic monitoring to assess the volume status. Hypernatremia increases the MAC for inhalational agents, but its clinical significance is more closely related to the fluid deficits. Hypovolemia again attenuates any vasodilatation or cardiac depression from the anesthetic agents and predisposes to hypotension and hypoperfusion of tissues. So there is decrease in the volume of distribution of IV agents, and there's also a decrease in cardiac output. Elective surgery should be postponed in patients with significant hypernatremia, that is more than 150 milliequivalents per liter, until the cause is established and fluid deficit is corrected. So sodium is the principal determinant for the total body water, both in the intracellular and extracellular fluid compartments. And a single variable, extracellular volume, can be used to understand, identify, and correct the osmotic impact of hyponatremia and hypernatremia. So after we've finished with sodium, let's move on to potassium. So potassium is a major intracellular cation. More than 90% is intracellular. Normal value ranges from 3.5 to 5.5 millimole per liter. And the sodium potassium ATPase actively transports sodium out and potassium in of the cell in the ratio of 2:3. Hypokalemia is defined as a potassium level of less than 3.5 millimole per liter, and the causes can be divided into decreased intake and redistribution into the cells. Now, when you talk about redistribution, it is the acid-base disorders firstly, like metabolic alkalosis, hormone-induced like insulin and beta-2 adrenergic agonists, anabolic states like vitamin B12 and folic acid, and TPN. Others, again, you have pseudo-hypokalemia, hypothermia, and hypokalemic periodic paralysis. Then another cause can be increased loss, which again can be divided into non-renal and renal, like others. So non-renal will be the GI losses, integumentary losses. Renal causes will be the increased distal flow by diuretics, osmotic diuresis, or salt-wasting nephropathies. And conditions with the serum increased secretion of potassium is happening, like mineralocorticoid excess or distal delivery of non-reabsorbed anions. Other important causes of renal resulting in hypokalemia are amphotericin B and hypomagnesemia. So hypomagnesemia is a very important cause, and sometimes when there is refractory hypokalemia, you must think of hypomagnesemia. Redistribution in the cells. Metabolic alkalosis, as we know, is a common cause for this. And while treatment of decay, insulin results in hypokalemia. Then stress-induced catecholamine release and beta-2 adrenergic agonists also cause in redistribution to the cells and hypokalemia. Magnesium deficiency and hypokalemia, that we have said at refractory hypokalemia, we must think of hypomagnesemia. Because with hypokalemia, as with hypomagnesemia, the distal nephron may lose both magnesium and potassium. So clinical features of hyponatremia, it's normally asymptomatic less than 3. And then what you have in the ECG is T wave flattening. You see the normal ECG here, and this is hyperkalemia in which there are tall tented T waves. And here you have hypokalemia in which there is a flattened T wave and appearance of U wave. So T wave flattening and inversion of the QRS complex are seen. Prominent U waves are commonly seen at serum potassium levels of less than 2.7 milliequivalents per liter. There is increased myocardial cell automaticity and risk of arrhythmias, especially with genetic or acquired prolongation of the QT syndrome. Labile arterial blood pressures are seen, and hypokalemia also predisposes to digoxin toxicity. Neuromuscular effects like skeletal muscle weakness, tetany, and cramping. And in renal, you'll have polyuria and hypochloremic metabolic alkalosis, which is commonly diuretic induced. In metabolic, you'll have negative nitrogen balance, hormonal, there'll be decreased insulin secretion and decreased aldosterone secretion. And hypokalemia is implicated in the pathophysiology and progression of hypertension, heart failure, and vascular disease and stroke. So chronic hypokalemia has significant metabolic effects in the body. Again, diagnostic approach should focus on history of medications. Lab evaluation should include all the routine tests plus urine pH and osmolality and urine electrolytes. And other tests which include urine calcium, thyroid function test, and aldosterone levels. Now, this is a diagnostic evaluation for hypokalemia, in which you do the urine potassium. If it is less than 30 milliequivalents, you think of extra-renal causes like diarrhea. And if the urine potassium is more than 30 milliequivalents per liter, then you see the urine chloride. If it is less than 15, then you think of NG drainage and alkalosis are the causes. Or if it is more than 25 milliequivalents per liter, then you think of diuretic induced and concomitant magnesium depletion. So the management, the goals will be correction of the potassium deficit and minimize the ongoing losses. So generally it is safer to correct hypokalemia by the oral route. Urgency depends on the severity of hypokalemia, the associated cardiac disease or digoxin therapy, and the rate of decline in serum sodium concentration. Urgent and cautious potassium replacement should be considered for patients with severe hypokalemia, less than 2.5 millimole, or when serious complications are there. Oral replacement with potassium chloride is the mainstay of treatment for hypokalemia. Potassium bicarbonate and citrate are used to alkalize the patient. That would be more appropriate when hypokalemia is a result of chronic diarrhea or RTA. IV therapy is when the patient is not able to take anything by mouth or when the hypokalemia is severe. IV potassium chloride can be administered via peripheral vein, and the dose is 20 to 40 millimole per liter, and higher concentrations can cause localized pain, clinical phlebitis, irritation, and sclerosis. If the hypokalemia is severe, less than 2.5 millimole per liter, and the patient is symptomatic, then you can consider supplementing with a central vein with cardiac monitoring in the ICU at a rate of 10 to 20 millimole per hour, and the absolute administration should be restricted to 20 millimole in 100 ml of saline to prevent accidental infusion of a large dose. Importance to the anesthetist. The decision to proceed for elective surgery is arbitrary based on the lower limit somewhere between 3 to 3.5 milliequivalents per liter. It also depends on the rate at which the hypokalemia has developed and the presence or absence of secondary organ damage. In general, chronic mild hypokalemia without ECG changes does not appear to substantially increase the anesthetic risk. As a rule, patients undergoing elective surgery should have normal potassium levels. However, delaying a surgery is not recommended if the potassium levels are above 2.8 or below 5.9. Patients receiving digoxin are at an increased risk of digoxin toxicity. So in them, the plasma potassium levels more than 4 milliequivalents are desirable. It is prudent to correct significant hypokalemia, especially when there are risk factors like dysrhythmias in CCF patients and those on digoxin therapy and ECG evidence of hypokalemia. Potassium levels should be frequently measured if repletion is going on or changes resulting from drug, surgical progress, or ventilation are expected. So let's lastly come to hyperkalemia. So what is hyperkalemia? It is defined as a potassium concentration of more than 5.5 millicoulins per liter. It occurs in about 10% of the hospitalized patients, and more than 6 is associated with 1% increased risk of mortality. Common causes are decreased renal excretion, which is the most common cause. And it is defined again according to the causes: renal failure, which further has causes with impaired sodium reabsorption and increased chloride reabsorption. Pseudohyperkalemia is another entity in which there is artificially increased potassium levels due to the movement of potassium out of the cells. For example, immediately following a venipuncture, prolonged tonic use. Transcellular shift, the opposite of hypokalemia. In there it was alkalosis, here it is acidosis. And you have rhabdomyolysis and hyperosmolality like hypertonic saline or mannitol when it is infused. Drugs associated are beta blockers, digitalis, and for us it is the succinylcholine. Impaired renal excretion because of various drugs affecting the renin-angiotensin-aldosterone mechanism, NSAIDs and heparin. Blood transfusion can again result, especially blood which is more than 14 days old. The plasma potassium content increases from 4.4 and 3.1 millicoulins per liter for packed cells. So blood which is more than 14 days old, whole blood, or if it is packed cell, has an increased risk of creating hyperkalemia. Clinical manifestations range from sinus bradycardia, sinus arrest, and slow idioventricular rhythm to ventricular fibrillation and asystole. Skeletal muscle weakness are seen when the potassium concentration is more than 8 millicoulins per liter. And contractility, however, is well preserved. So hypocalcemia, hyponatremia, and acidosis attenuate the cardiac effects. So in this ECG, we see the symmetrically peaked T waves, loss of the P wave complex, which occurs at 6.5 to 7.5 potassium levels, widening of the QRS complex, prolongation of PR interval, and sine wave pattern at levels more than 8, finally can terminate into VF and asystole. Diagnostic approach: assess the need for emergency treatment, history, physical examination, lab tests, which include all the routine analysis, plus urine pH, osmolality, creatinine. Another ratio which has been used is the transtubular potassium gradient, which is calculated by this formula. And if it is less than 3 in the presence of hypokalemia, and if it is more than 7.8, it presents hyperkalemia. So this ratio has been used as a quick estimate for hypokalemia or hyperkalemia. Treatment should depend as a medical emergency and it should be treated urgently. Patients with significant hyperkalemia of more than 6.5 millimole in the absence of ECG changes should be aggressively managed. Aims is to reverse the cardiac manifestations, improve the skeletal muscle weakness, and restoring the potassium back to normal. So for that, you have various agents. The first is membrane antagonism, in which calcium is of primary importance. So calcium raises the action potential threshold and reduces the excitability. It can be used as 10% calcium gluconate, 5 to 10 ml, or 10% calcium chloride, 3 to 5 ml. So the dose can be repeated if there is no response. It is commonly administered as 100 ml of 5% dextrose in water and infused over 20 to 30 minutes to avoid acute hypercalcemia. Cautiously use it in patients on digoxin therapy because hypercalcemia can potentiate the digitalis cardiotoxicity. Second mechanism for correction is the transcellular shift. So you combine insulin and dextrose, which will drive the potassium into the cells. 10 to 20 units of regular insulin in 25 to 50 gram of glucose. It is administered, and the potassium concentration will fall by 0.5 to 1.5 millimole per liter in the 15 to 30 minutes. Soda bicarbonate is another agent which helps in transcellular shift. And then we have the beta-2 adrenergic agonist also. The recommended dose is inhaled albuterol 10 to 20 milligram, nebulized in 4 ml of normal saline. The third mechanism for correction is enhanced clearance, which can be accompanied with furosemide, non-absorbable cation exchange resins, and dialysis. So dialysis is normally for severe hyperkalemia and refractory. The rate of removal with hemodialysis is faster and is more effective than peritoneal dialysis. Importance to the anesthetist: it is recommended that serum potassium concentration should be less than 5.5 millicoulins per liter for elective surgery, and hypoventilation, respiratory, or metabolic acidosis can further worsen the problem of hyperkalemia. So Succinylcholine, which increases the serum potassium by 0.5 millicoulomb per liter, is best avoided. The effects of muscle relaxants also may be exaggerated by the weakness from hyperkalemia. Potassium-containing fluids like ringer lactate, which increase the serum potassium levels, should be avoided. So if the potassium is more than 6.5 millicoulomb per liter, please go ahead with dialysis, especially in the presence of anuric renal failure. So plasma potassium, to summarize, is only the tip of the icebergs in evaluating the total body potassium. And potassium defects are often largely than suspected as hypokalemia, even in mild cases. So hypokalemia is well tolerated largely and is not at the risk for serious arrhythmias unless combined with other arrhythmogenic conditions like ACS. So when hypokalemia is resistant, think of magnesium deficiency. And when you're using calcium to antagonize the cardiac effects of hyperkalemia, make sure that the decrease in potassium is best done with insulin and glucose. And begin that to remove the potassium by increased clearance by the resins, K-oxalate resins. So understanding this sodium and potassium electrolyte disorders is of vital importance. And for that, you need to understand the fluid mechanisms which are there in the body. And regular revision of this is of prime importance. Thank you so much.
Thank you, Dr. Michelle, for having covered up this topic in such a simple, lucid, and comprehensive manner, and also sticking to the time limit.
Thank you,
and as rightfully said, this is a topic which needs to be revised over and over and over again.
Yes, ma'am.
Very nicely summed up. And
thank you,
thank you so much. I don't see any questions in the chat box.
Yes, ma'am.
Which means I think the residents have understood it very well. Thank you,
Thank
Michelle.
you so much, ma'am. Thank you, ma'am.
So I guess we now move on to the next topic of calcium, magnesium, and phosphorus. And we now have Dr. Santvantana. She's an associate professor in VMMC and Safdarjung Hospital. Her main area of interest is critical care, emergency medicine, obs anesthesia, and onco anesthesia. So,